Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Moderna, Inc.
Hi, this is Dr. Michael Davis. I am the president-elect of the Society of Melanoma Research, and I am chair and professor of the Department of Melanoma Medical Oncology at the University of Texas MD Anderson Cancer Center. And it is my pleasure to introduce our podcast for today, Advances in the Treatments and Outcomes for Melanoma Patients with Brain Metastases. Our guest today is Dr. Hussein Tabi, who is professor in the Department of Melanoma Medical Oncology here at MD Anderson and co-director of the MD Anderson Brain Metastasis Clinic. Dr. Tabi, thank you so much for joining us today.
Thank you so much for having me. I'm really looking forward to our discussion.
So just as a starting place, can you talk about why having knowledge about the diagnosis and treatment of CNS metastasis is so important in the care of melanoma patients?
That's a very important question, Mike, and I think a critical component of how we take care of patients with metastatic melanoma. As you know, metastatic melanoma is a disease that has the highest propensity of almost any solid tumor to go to the brain. And we know that our patients with metastatic disease on day one have up to 40% of the time have brain metastases already in place. And over time, we know that at some point during the course of their disease, they will end up facing the prospect of a brain metastases. We know from autopsy series that up to 80% will have brain metastases at the time of death. So it's a very important aspect for the care of patients with metastatic disease because it can change what we could do for them. We may have to manage their brain metastases differently than the rest of their metastases outside the brain. As we will talk a little bit later, we may actually have different therapeutic modalities that we can include. And again, will dictate the course of their therapy in general. I think one of the very important aspects to bring up is that in other cancers like lung and breast cancer, where brain metastases do happen, the typical clinical management is to check for brain metastases or perform brain imaging only when patients experience symptoms, which is not the practice that we recommend in melanoma, because as I just mentioned, those patients have a high incidence of brain metastases. And so we highly recommend doing brain MRIs as part of the initial staging, and again at the time of restaging for assessing the impact of therapy.
Thank you so much. That's a great introduction to the topic. And so, as you sort of alluded to, there are really sort of multiple different types of treatments that are used in the management of patients with melanoma that have brain metastases. Can you talk briefly about these different modalities and sort of the rationale for a multimodality evaluation of patients with CNS involvement?
Yeah, so actually, as we have modalities to treat extracranial disease, we do have the three kind of pillars of oncology, right? We have surgical interventions, we have radiation therapy, and then we have systemic therapy. So in that regard, we do have the option of using those approaches. However, the brain is the most delicate organ that we have. It has a very direct impact on the patient's functioning and overall quality of life, let alone the kind of the morbidity, the mortality that can happen because of brain metastases. And so as we think about which modality to deploy, we really have to think about what are we kind of damaging in the process. And so to start with radiation, I think radiation is actually one of our most effective approaches for brain metastases. And there are two different approaches to radiating the brain. One of them is the whole brain radiation, which includes relatively high fractions given over 10 days, and has some therapeutic impact, but you can imagine affects normal brain tissue quite a bit and is well known to affect cognitive function and memory and so on. And that approach may work very well for patients with lung cancer or breast cancer or other malignancies. Unfortunately, for melanoma, it is less effective because melanoma is known to be a radio-resistant tumor in general. So you just need higher doses of radiation to be able to affect cell kill for a particular melanoma cell, which is why another modality that has really transformed the care of those patients is stereotactic radiosurgery, which can be delivered in multiple ways. But the idea is that you can deliver a really high dose to a very small area of the brain. That ability to concentrate the dose in one spot can really allow us to deliver lethal doses. So even melanoma cells die and can spare normal tissue, so that decreases the toxicity of that approach. On the other hand, one has to think about the fact that with stereotactic radiosurgery, or with surgery, as we'll mention briefly, you're only tackling the one metastasis that you're actually targeting. So it's local therapy for the few metastases that you can target, and it has no impact on the incidence of additional metastases across the rest of the brain, or any impact outside the brain. So that's for radiation. For surgery, I think surgery is a very effective method to deal with some brain metastases, but it's typically reserved for patients that present with usually a large lesion that is either a hemorrhagic metastases or a tumor that is causing significant mass effect. And it's typically more of a, I wouldn't say emergent, but not really an elective procedure. It's really something we have to do to be able to help the patients manage their symptoms. So those are the two modalities that are local therapies. As we'll discuss briefly, systemic therapy with both targeted and immunotherapy has been proven in studies that some of them you have led yourself, Dr. Davis, and I have personally participated and led some of them, that we can really have a significant impact in the brain with response rates that are quite effective, which we can go into more details a little later. But the idea is systemic therapy is capable of controlling brain metastases, as with systemic therapy, not just one at a time, but potentially all of them, as well as helping extracranial disease. And so thankfully, we have 3 different modalities that can really serve our patients. The question is, which one should come first? How do we choose to do, or how do we sequence them or potentially combine them in a particular patient's case? And frankly, as much as I've taken care of those patients over my career in medical oncology, I still am very limited in my knowledge of how to deploy radiation approaches, and obviously same thing for surgery. So taking in the input of our radiation oncologist and our neurosurgeon in deciding the care of a particular patient is critical. Sometimes I look at a brain MRI and say, oh, this patient should be fine if I treat with targeted therapy or with immunotherapy. I'll be able to shrink down their disease. And my colleagues would look at the MRI and say, but wait a second, this tumor is only 3 millimeters, but is sitting so close to the optic nerve. Even 1 millimeter in size increase or progression can really affect this patient significantly, and we should radiate first instead. And so in situations like that, being able to consult with each other on the ability of our different modalities to help those patients and think about which one we should deploy first is incredibly helpful and really can maximize the care of those patients.
That's a great summary, Hussein. So as you know, I mean, in the past, when we talked about systemic therapy for brain metastases, the agent that was often used was temozolomide, a chemotherapy that could cross the blood-brain barrier. But only achieved responses in about 5% of patients. And what's been so exciting over the last few years is dramatic changes in the efficacy of our systemic therapies, particularly immunotherapy, even for patients with brain metastases. So I often have patients or even healthcare providers who really think that systemic therapy doesn't have a role for brain metastases. But can you talk about sort of the exciting results that we've seen the last few years?
Absolutely. You make a really great point. I will say before the advent of all of our neurotherapies, you had published some data showing that the 1 year survival for patients with brain metastases was less than 20%. And so with temozolomide, the issue is the drug is capable of getting into the brain. However, it's just not effective against melanoma. It's only about 10%, whether inside or outside the brain. So the idea that we now have treatments that once they reach the tumor are capable of actually inducing cell death and helping patients has really dramatically transformed our approach. So targeted therapy is as such, it's actually capable of inducing responses in the brain up to 58%. And one of the studies that you have led, Mike, called COMBI-MB, and showed that you can have that effect relatively quickly. One of the limitations of targeted therapy is how long the responses are, how durable, but still you can get at least 6 months of control, which is really important for this population. With immunotherapy, combination immunotherapy with ipilimumab and nivolumab has shown that we can induce responses in about the same rate, so 55 to 57%, similar to what we do with therapy. However, the most important aspects of those responses are two. One, they happen quickly. So the median time to response was 6 weeks, which is very important for this population. And second, they're highly durable. We just reported last year in Lancet Oncology the 3 year data. And at 3 years, 87% of the responses were maintained. And so, again, this is a situation where a patient presents with multiple brain metastases. And with treating them with 4 doses of ipi and nivo as an induction and then as maintenance, you can give them up to 55% durable control of their brain metastases. So those are kind of the current drugs in our armamentarium that will help us make decisions and potentially alleviate the impact on morbidity from brain metastases.
And I think one of the other things that's been remarkable is with the demonstration of those results is we're now actually also seeing more clinical trials designed specifically for patients with brain metastases, whereas these patients historically were almost universally excluded from clinical trials. So it's really opening up the treatment options for these patients. So maybe just as a final word then, as Hussein is, you see lots of patients who have newly diagnosed brain metastases and wondering just if you have any general sort of thoughts about how you approach these patients or advice for other caregivers about how to consider these patients.
Absolutely. I think the first and most important concept is you need to check. And again, melanoma patients are unique. Frankly, I think breast and lung patients in specific cases also need to be screened, even if they're not symptomatic. But in case of melanoma, screen the brain if the patient has already evidence of metastatic disease, because more likely than not, you will find brain metastases. And second, I really do feel strongly about reaching out to our radiation oncologists and our neurosurgeons. Obviously, radiation oncology more consistently, since not all patients will require a surgical intervention, but radiation oncology is our amazing and important partners, and being able to think through what would need to be treated with gamma knives, stereotactic radiosurgery versus systemic therapy, and honestly delaying whole brain if possible, because it's not a very effective approach. Those are the things that I generally think about as I treat patients with brain metastases.
Well, I think the take home again is that melanoma has a very high risk of brain metastasis. And while historically these patients have had very poor outcomes, those outcomes have improved dramatically due to advances in systemic therapies, advances in radiation, and certainly, again, the engagement of the multidisciplinary approach to these patients. So, Dr. Tabi, thank you again so much for joining us for today and for sharing your expertise and perspective.
Thank you for the opportunity. And to your point, an exciting time for our patients with brain metastases, but there's still a lot of work to be done, and definitely more systemic therapy agents, hopefully, that we can develop in this space. Thank you so much for the invitation.